for a VR surgery. So over to you, sir.
Thanks everyone, and it's been nice to see the discussions going on. The very fact that we have so many questions and discussions means that there is nothing consolidated about it. These are all guidelines and they can be variable based in place to place. I thank Anand and Manisha for making me part of this wonderful webinar. I'm going to talk about preoperative evaluation of a patient who needs to undergo retinal surgery in the COVID era. And most of the guidelines, what we talked about, is based on the preferred practice patterns published recently by Indian Journal of Ophthalmology. Of course, the basic premise that they're all working on is highlighted here in this article, where it says that all the patients should be assumed to be potentially carriers of the virus throughout the duration of their stay. So the basic premise with which we all work is that all the patients and their attendants should be considered potentially infective. So this is the premise with which we are all working. And the pre-op evaluation can be divided into four different areas. One is a special consent. I think this has been talked about already by Mahesh and others also. This is taken for all patients when they enter the hospital, and this is needed to reduce the liability to the doctor and the hospital. As Mahesh pointed out, at this point of time, we have no idea how legally this is valid, but it is better to take this consent so that the patient also realizes that there is some risk involved in coming to the hospital and getting examined, even though the hospital and the doctors and the patient himself may take the best efforts. Despite that, there is a risk of infection. It is better that the patient is made aware of it, and we are using the COVID-19 Pandemic Emergency Ophthalmic Treatment Consent form that's given out by the All India Ophthalmic Society, which is available at kios.org. Now, this is also used as it is incorporated into the surgical consent for any surgery that you do, whether it's a retinal detachment or injection or whatever. Please include this also along with that particular consent for that specific surgery. So this is important to make sure that you have a special consent also taken for all patients, before you do the surgery. Now, it's important that comorbid conditions like diabetes, hypertension, patients with chronic kidney disease, they need to be optimally controlled and they should really be fit before you undertake any surgery. And therefore, it is desirable that you ask them to get a fitness from a physician in these times, especially COVID era. We know that these patients are at higher risk for mortality and morbidity if they contract COVID. And if patient has uncontrolled diabetes or hypertension or some other systemic problem which does not make him fit, then you may have to really postpone him till he is really fit, and you may not be able to take him up for surgery. COVID-related workup is something that has always gathered a lot of attention and a lot of discussion. I am sure this is going to rake up a lot of discussion today. Now, one thing I want to emphasize here is that often in our practice, the patient comes in and has a problem and needs surgery. And it takes few days and even sometimes a week before the surgery is scheduled for a variety of reasons. So it's important when the patient comes in for surgery, you repeat the questions regarding the COVID symptom in the interim period. Has he had any fever, sore throat, cough, etc.? Has he been exposed, either himself or family members? Have they had any contact with the infected person? It's important to repeat this history of COVID symptoms and history of exposure, because there could be a time gap between the examination and scheduling of surgery. There are 3 tests that are often done to find out whether the patient is suffering from COVID infection or not. Let's look at each 3 of them. The gold standard today for finding out whether the patient has a COVID or not is a RT-PCR testing, and this is being done in many laboratories in India. Most of the testing centers in India are all in the government setup, and ICMR has given very strict guidelines as to which patients need to undergo this PCR testing. Everybody cannot undergo this. Only these 4-5 categories of patients can be sent for testing for PCR. And recently, in the last month or so, government has allowed many private labs also to open up and do these testing. Despite this, the availability of PCR testing for general public and for our patients who need to undergo surgery is a big question mark today. Therefore, although it's a gold standard test for RT-PCR, we cannot probably insist on this for every patient. Look at the contrast in United Kingdom. they insist on a PCR and antibody testing for all patients who are having planned surgical patients, and then they go on to define how to deal with them once they get both the tests. Today we are not in that safe position. So although we should insist that preoperatively all patients should get a COVID swab testing done, we may not be able to do this because of practical problems. In Bangalore, the test is done in mostly government centers. The private labs are charging 4,500 rupees. Today, if you ask a patient to undergo the test, the increased cost could be a major problem in getting the test done. And most of the times, the 24 hours is the time involved to get the report back, and therefore it could be another stumbling block to get the PCR test done in our patients. I am told that in Delhi and maybe in other metros as well, doctors are insisting on COVID testing before surgery and they are getting it done. I don't know, I would like to know the view of the other people in the other metros regarding this. But in Bangalore, I don't think we're able to get the PCR test done for all our patients preoperatively. And even the AIOS guideline does not recommend it as a routine. However, to confound matters and put confusion into the minds of all of us, there is a recent central government directive which says that all inpatients in every hospital should undergo a COVID testing, even though they are not suffering from COVID, they are admitted for a variety of other reasons and they should all undergo COVID testing. However, this guideline has not been approved by ICMR as of now, and therefore we don't know as of now. So as of now, COVID testing, although it is a gold standard, may not be possible in all patients. What about the rapid antibody test? The problem with this is that it can only become positive after the patient is infected, and even then it takes some 7 to 11 days. And therefore, it does not help us if the patient is in the first 7 to 14 days before he develops the antibodies. If this is negative, it doesn't really help us. Whereas if it is positive, maybe we can defer the surgery or tell the patient that you have COVID and we cannot operate on you. And recently, there have been a lot of doubts raised about the validity and the accuracy of these tests in the media. And ICMR was forced to withdraw all the test kits and suspend the rapid antibody testing. It started about a week ago. So as of now, I don't think this is recommended as a routine pre-op test in our patients. Let's look at another modality called chest X-ray. Now, chest X-ray is important because lung is one of the major organs affected in COVID, and chest X-ray changes are seen in almost all the patients with COVID. And in situations where the patient comes to the hospital with COVID infection suspicion, that's a very good test to do because the PCR test can take 24 hours to 48 hours to come back. Meanwhile, the treating physician can use a chest X-ray to really determine whether this patient has a COVID infection or not. But our situation is different. We are not having a patient suffering from COVID, but we are having a patient in whom we want to rule out COVID. Nevertheless, chest X-ray could be a good screening test in our patients who may be having asymptomatic COVID and they may even be having asymptomatic lung disease. And chest X-ray could pick up these patients and we would be able to probably make sure that we don't operate on these patients. And this is also recommended as a preoperative test by the AIOS guideline. So when it comes to OT scheduling, whenever we schedule any surgery or any patient who walks into the hospital, we have to inform the reception to tell them that all the protocols they have to follow. They have to bring only one attendant. I think this has been stressed by all the speakers, including Mahesh. So they have to wear a mask, hand hygiene has to be followed, and social distancing has to be followed. So this is no different from patient who walks in to have a surgery done. And all the surgeries have to be daycare only. And therefore, we need to limit the number of surgeries because there is a recommendation that between the two surgeries, we need a time gap of 20 to 30 minutes for the OT air to get exchanged. I am sure Hemant will touch upon this in much more detail. But suffice it to say that we have to limit the number of surgeries so that also it avoids crowding in the wards. And at the same time, ask the patient to come at different times, stagger the timing at which the patients report to the hospital. So this also avoids crowding in the ward, crowding in the cash counter, and crowding at the discharge place, etc. Entry point temperature has been stressed about, hand sanitization when the patient enters the hospital, encouraging digital payment, and allotting beds to keep social distancing. This is very important. If you have 10 beds, you may have to utilize only 3 or 4 beds to maintain social distancing. And strictly insist on one attendant per patient, and all of them to need to wear masks. The staff nurse in the ward needs to wear a cap, mask, and probably a shield, and they can minimize the exposure, and putting drops like, maintaining a distance like this and using dilating drops at home is a good way to reduce the interaction or the close contact between the staff and the patient. And always ensure that procedures like cannula insertion is done by the senior nurse. The idea is that minimum time is spent as close to the patient as possible. So everything has to be done efficiently. I think this has been stressed very well by Raja and Mahesh, that your efficiency, if it increases, then it decreases the duration of the patient's stay in the hospital. Again, once the operation is done, patient goes, and at the end of the day, when you leave, make sure that you dispose of all the waste generated in the proper way. The mask, the gloves, the cap, everything needs to be disposed of in an appropriate way. And even when we are giving post-operative instruction, it is very important to maintain social distancing. It may be a good idea to give handouts rather than giving verbal instructions lasting for more than 10 to 15 minutes. Instead of that, you can give out handouts and ask the patient to go through and call you if he has any doubt. Encourage the patient to phone in and clear his doubts, instead of spending time close to the patient giving these instructions. And once the patient is discharged, it's important to clean the bed, the floor, the door handle, etc., and dispose of the whatever you want. The patient was wearing the hospital dress. This has to be disinfected appropriately between each patient, and this is something that has to be really taken care of. Lastly, operating on a patient who is already having a COVID infection. I think this will be debated further, but as of now, only if a patient suffering from COVID infection, he needs to be operated only if he has a real vision-threatening emergency, and it cannot wait for 2 to 4 weeks till the patient recovers. And obviously, it can be done only in a multi-speciality hospital equipped to handle all COVID patients. So definitely, most of the setups that we work in do not have this kind of infrastructure, and therefore, we probably have to either refer these patients to centers that have ability to handle these patients, or we may have to defer the surgery till the patient recovers from his COVID infection. And of course, in these patients, GA should be avoided, and aerosol generating procedures has to be avoided, and this has been discussed in detail. So I think in short, most of us are not able to operate on a patient who is suffering from COVID, who has any ocular emergency, and probably are forced to refer him to another center which is equipped to handle this. So finally, take-home message is that COVID scenario is likely to continue for indefinite period, friends. It's not going to end by end of May or end of June. So therefore, we need to institute and follow these protocols probably indefinitely. And therefore, it is better that all of us and all our staff, get to know these protocols and get to learn them, and it becomes a second habit. Therefore, the safety of all of them is guaranteed, or at least taken care of. And still remember, the basic premise is treat everyone as if he or she is COVID infected and then proceed. OT scheduling has to be done appropriately. Admissions have to be planned as per avoiding the social crowding, and special consent I've already stressed about needs to be taken. This is the most debatable issue here today, will be the RT-PCR preoperatively for all, whether we do it, how we do it. This is again a very gray area, and this probably we'll end up spending a lot of time discussing this point. And please do not forget to maintain social distancing, hand hygiene at the ward also, and institute proper protective equipment for all the staff, for all the duties, whatever they are doing. So these are all the challenges that we are facing now, and at the end of the day, efficiency improvement will definitely minimize the duration of the stay patient as in the hospital. Probably we can train our patients to take appointments and come, avoid walk-ins. Probably we can train our patients better. Ultimately,